Thank you very much, and excited to have the opportunity to speak. Sort of a very broad topic here, so I'll just sort of give you some highlights of some of the thinking coming out of British Columbia. I don't think I have any relevant disclosures for today, and in terms of my talk, I'll try and hit the high notes on some thinking on things that are emerging in the area of harm reduction, addiction treatment, and I think certainly we're all grappling as researchers and care providers on the obvious need for new models. So first of all, harm reduction. What a boring topic, hey? You guys have heard that talk before. What can I say? For people from Canada or others who have followed the drug policy landscape in Canada, you'll know that supervised injecting has been something that we've been working on after initially being sort of pioneered in Europe and to some extent elsewhere. But the thing in terms of harm reduction, of course, is the emergence of fentanyl, and certainly in British Columbia and Alberta, the province we're in here, and sort of spreading eastward, this has been a problem. And of course, in certain areas in the United States as well, this has just been a huge, huge problem. So this is the program in Vancouver. I probably can't say much about it more than you already know. It's a place where people can take pre-obtained illicit drugs and inject them under medical supervision. I guess the point that I'd leave you with, and I think we've sort of made this point quite emphatically in British Columbia now, as we now have overdose prevention sites as well. And there's been a whole proliferation of essentially unsanctioned places where people can inject under supervision. And it gets sort of bogged down in a legal quagmire, I think, when people think about supervised injecting. And I'll just leave you with my personal belief that it's really just syringe exchange programs, and these programs can be governed in a similar way. All it really is giving out a needle, and then there's this sort of effort to have the needle not end up in a park or some other place where it could be a community concern, or someone could be offered healthcare at the same time that they use that needle, and of course preventing an overdose. But really, I just really don't understand, not being a lawyer, the difference between these interventions. But of course they're still controversial. This is sort of an outdated image, but it's quite funny, and I think sort of touches on how controversial these can be. Before the supervised injecting facility opened in British Columbia, the White House actually dispatched their drug czar to come and speak at the Vancouver Board of Trade and warned, about all the drug users from the United States that would be coming to Canada if we were to open this little clinic. And then, of course, the government changed after Insight opened, and the next federal government really wanted it closed and took this all the way to the federal Supreme Court in trying to do so. And that basically had this little clinic up against the federal government, and this sort of ideological divide emerged that I think was actually extremely problematic. Of course, there's been a lot of research done, and most of you are probably at least peripherally familiar with some of this. This is just one example, a paper by my colleague Thomas Kerr, where we were fortunate that there was a study independent of the injecting facility that was in the community before Insight opened, and then you could look at behavior after it opened. And basically, he was able to show a pretty substantial reduction in syringe sharing associated with the use of the program, which I think is a relevant observation for the hepatitis C community. But of course, this sort of ideological divide with those opposed to it, this type of evidence being a different type of evidence than they were working with. This is an example of one of our national newspapers, an editorial, and then the sort of groups opposed to one another, where one might have a wealth of evidence, but the others are in a position of power when it came to the federal government, or just the general sort of approach where people are disagreeing, and they're disagreeing very publicly. So the sort of media landscape being one where there would be something about harm reduction, and the journalists would speak to the go-to person who was in support and the go-to person who was opposed, and they've got their nice story sort of summarizing the issue and moving on from there. This would be another example, a smaller sort of newspaper locally in Vancouver, doctors studying the site. than one of our elected officials at that time. He's actually a really nice guy, but this is a kind of humorous other anecdote saying that the information that comes out of Insight is spotty at best and not consistent with what he hears, that it's a joke. We were fortunate in that the funders of the evaluation had really pushed us to include process measures, so we were able to kind of see if this was true. And actually you can see here 95% of participants rated the overall quality as excellent or good. So you have this sort of inconsistency. I don't want to portray things as being all positive, because of course there were things that people wanted to see improved, but I think kind of highlights this very toxic, for lack of a better word, kind of policy environment where you have groups really opposed and vocally opposed to things. And in that context, I think it's worth talking about the limits of harm reduction. And I think when the federal government certainly had its sights on this program, a lot of the community groups, really wanting to keep harm reduction as a viable option for people, really kind of pushing the limits of what harm reduction can do in terms of being a panacea. And I think this sort of, I just did a screen capture, is really making the case for supervised injecting and not having needles out in the community. But of course, just acknowledging the limits, I think, is quite important. And then what really, I think, undermines so much of this ideologically is the philosophy that we really need to stop people from using drugs. And this is actually from a United Nations poster from some time ago, this sort of really, quite frankly, preposterous notion that we could actually create a drug-free world. I actually went to the wrong conference across the way, the big gastroenterology conference, to think you could have a drug-free world with the pharmaceutical industry representation over there. It's something to see. You guys should go over and see the sponsors area. It's incredible. But this obviously manifests in the community, this sort of ideology and this approach on our TV screens and in our communities with this sort of cat and mouse game, trying to suppress the drug market. And from a sort of hepatitis C perspective, for people that know the epidemiology of hepatitis C and HIV in Vancouver, although it was multifactorial, among the origins of the epidemic were these efforts to try and really push people out of the public eye and into single room occupancy hotels and other hidden environments where, of course, we know it's difficult to reach people with harm reduction and there's a lot of syringe sharing and other problems. In terms of the limitations, this is probably a good example. This is actually 100 kilograms of pure heroin that was brought into the ports of Vancouver. Again, this is some time ago. We actually had a subsequent paper in the Canadian Medical Association Journal that I'd be happy to share with people that basically showed that this seizure was just a marker for the huge wave of heroin that was coming into the country at that time. The price of heroin was going down, the potency was going up, overdoses were going up, and certainly this was just kind of like I guess I'll use a hockey analogy. If you shoot enough pucks at the goal, you're going to hit the goalie sometimes, and that's this was an example of that. There's obviously really good international data on this. So this is from the Global Commission on Drug Policy, looking at U.S. data. The blue histogram there is the sort of inflation-adjusted increase in expenditures on supply reduction efforts by the federal government. The green line going down is actually the price of heroin, and that wasn't because heroin was becoming sort of less quality and you couldn't ask as much money for it. The red line going up along with the histogram is actually the potency of heroin. So despite these efforts to try and control these markets, organized crime and the disorganized crime and the economic factors are just too strong. And then, of course, we have the lessons from Prohibition as well, of course, the violence and corruption and everything that went along with alcohol prohibition, which I think is sort of accepted in our culture. Like, we know that happened. There's HBO series about it, and we know the problems that there were during that time, but we haven't kind of drawn the connection in many ways. This is actually from a drug bust in Mexico, if you've ever wondered what $300 million cash looks like. It's actually some Canadian money, I think, in the front there. Currency exchange is not as it once was, but that's what they're fighting over. This is like a cartel member who actually got caught. So think of the cartel members who are a little bit smarter. But this is the forces that drive this market. And then, of course, the sort of the violence that are in our streets. And for folks here from Alberta, we see it in the media monitoring of British Columbia, the gang violence and stuff that you're experiencing in this province. In British Columbia, it's just become a fact of life, and it's not front page news anymore. It's more sort of page 3, where the gang fight for control of the drug turf is like just sort of an accepted sort of fact of life. And then, of course, there's the toxicity in the drug supply. And again, I think for the physicians in the room, they'll all remember when they had to calculate an anion gap and to figure out, was this potentially a toxic alcohol, which is really, I think, mostly a historical thing. I have actually never seen a case of methyl alcohol. But of course, during Prohibition, there was these toxic alcohols that were making their way into the food chain, basically, because of the approach with Prohibition. I didn't want to immediately reach to an opioid example of this, so this is actually an Alberta example that was quite easy to find. This is a case of kids dying from what was thought to be the street drug ecstasy, but is actually a sort of adulterant or a mistake of chemistry when people are trying to make this in basement laboratories called PMMA that can cause like a toxic hyperthermia reaction. So it's not just alcohol, it's actually all the drugs. And of course, with fentanyl that's being imported basically from China, it's believed, we now have an extremely toxic drug supply. And I was thinking to myself when I was preparing my slides, that Einstein quote about insanity as being defined as doing the same thing over and over again and expecting a different result. And I thought, that's such a cheesy quote. Everyone knows that one. But then I Googled and I found this, and I'd never seen it before, and it's actually pretty good, that we can't solve our problems with the same thinking as when we created them. And I think that's very pertinent to the drug problem we're dealing with right now. So in terms of British Columbia and the situation that we've been grappling with, a public health emergency was declared. We had almost 1,000 fatal overdoses last year. It's just kind of been getting worse, and now we actually have documented through urine drug screens that carfentanil is in the drug supply. So fentanyl is about 100 times more potent than heroin, they say, and people do not want fentanyl. Heroin is plenty potent if you can get heroin. But then carfentanil is a similar order of magnitude potent. And so what that means is by mass, you're dealing with sort of grain of salt size amounts that carfentanil also has the special property of being very long acting. So fentanyl is quite short acting, but carfentanil not only will it stop you breathing, but its half-life is for hours instead of like 10 minutes. And so this has just been a horrible situation where the morgues have been full in British Columbia because of the number of people that are dying. So the question is, what do? We've tried a number of things, and it's really the time to start thinking outside the box. Now this will be sort of very threatening to people. Our Prime Minister was meeting with people in British Columbia this morning, and I'm sure if this was proposed, he would have smiled and thought, yeah, I'd actually like to get reelected, or at least have that possibility. And so these are things that are very, very obviously controversial. But there's a group in British Columbia called the Health Officers Council. A number of us here are members. It's basically the public health physicians. And they've come up with some really interesting sort of concepts around this. And that if you look on the y-axis there with social problems going up, on the one side of the spectrum you would have prohibition, where there's violence and crime and the sort of Al Capone scenario. On the other hand, I think we got into this mess with overprescribing of OxyContin and related concerns, and that if we're too easygoing with potentially addictive substances, we need to be very careful. And there's probably a sweet spot in the middle where you can wage economic war on organized crime while at the same time using strategies to better protect society against increasing rates of unsafe drug use. And we have examples of this. There was the Naomi study that people I think may be familiar with, looking at diacetylmorphine, which is the drug name for, the trade name is heroin, versus methadone. So we actually have these models. I think this would be a model for regulation. Of course, this would be for a very selected group of individuals with severe opioid addiction. I thought this would be something interesting to share just in terms of like some of the out of the box thinking that's needed is actually just providing addiction treatment. So I think you'll all be familiar with the Cascade of Care framework, initially thought for HIV, and then also you'll be familiar with these cascades for hepatitis C. Working with, excuse me, Nora Volkow from the U.S. National Institute on Drug Abuse, we had a little commentary where we used the best data available for what the care cascade would look like in the United States. In Canada, I would argue it's about the same. We're probably about 1 in 10 people get any kind of treatment, and it's estimated that, again, about 1 in 10 would get any kind of treatment that would be sort of, what NIDA would define as treatment, as evidence-based psychosocial and medical treatment for addiction. Most of this 1 out of 10 would be sort of more peer support models and not evidence-based addiction treatment. So thinking outside the box, it's actually just doing some of the things we know. To kind of put that statement in context, this is just from a few weeks ago. This is from British Columbia's capital city, with a mother having to buy methadone on the street because they couldn't find a doctor that would prescribe methadone. The wait list in most sort of large urban areas in British Columbia outside of Vancouver, can be weeks to months to be able to get opioid agonist therapy. And then, of course, like we've just been sort of behind on the time, Suboxone is a generic now, and clearly it should be first-line treatment over methadone. We have a new guideline that we've released that basically talks about how these medications should be used. And for those that haven't seen this and are interested in the addiction medicine side of the equation that you're working on, actually also allows for slow-release oral morphine as an indicated treatment for opioid addiction, and their clinical trials to show the benefits of that. The other piece that we're really working with in terms of how to sort of change things is to go more to a primary care-based model for treatment. And I know within the success of the HIV response in many ways, and certainly I know this is part of the conversation with hepatitis C, is to get primary care physicians involved in treating hepatitis C. So we need to do the same thing with addiction. And this is an example making that argument in JAMA. This is in the Annals of Internal Medicine. I'm speaking as a specialist too. We need to have this become much more embraced within primary care, but of course that takes resources and ways of actually implementing things like that. For our part, the center that I'm with in Vancouver is doing a huge amount of healthcare provider training and really trying to change things in terms of access to treatment by engaging with care providers. We've sort of had a bit of a road show where we've gone and working with divisions of family practice. We've had about 800, mostly primary care physicians and nurse practitioners, participating in workshops in terms of how to prescribe Suboxone. Obviously, there's a limited amount that can be achieved in a workshop, but at least making people aware of this as an option. The other piece that we've been trying to do, sort of coming back around to my original comments about this ideological divide, is we've been doing a whole lot of work. It's been very time consuming, but to try and lower the temperature in terms of the sort of ideologically opposed groups. So we've been having lots of meetings with the recovery community who feels like they've been quite marginalized in terms of excuse me, the addiction response, and that they have a lot of expertise around recovery from addiction, and they're kind of put off to the side while the conversation happens around opioid agonist therapy or harm reduction. So we've had a lot of meetings with those groups and the peer groups and the family groups and law enforcement to sort of say, how can we all work together collaboratively on this? So if you're in an environment where you're trying to really bring about change, I encourage you to try something similar. So, 20 minutes goes by fast, but I think I've stayed on time. What can I leave you with in terms of lessons learned from this experience? Certainly, I think strategic thinking, as I've been alluded to sort of get past these kind of outdated approaches. We're in a crisis environment now with fentanyl, and I think that does present an opportunity to really start thinking strategically, and I just really encourage trying to bring like-minded people together, and if they have to agree to disagree, ideally not in the media. Totally new approach is required, but hopefully I've shared with you that even adequately funding addiction treatment would be crazy. Having primary care more involved is obviously the only way that I think we could realistically make care more accessible. And obviously in terms of responding to treatment, which of course will be critical for questions you're facing like reinfection and engaging people effectively in treatment, is going to require scaling up things that we know work, as well as looking at novel interventions and really moving forward with things that are effective. So I'll just acknowledge my peers and our supporters, and thank you for your attention.
Thank you very much, Evan.
Not bad,
Oops. Okay. Any questions? We have maybe time for 2 questions or comments. I was wondering if, how do you see 3-month therapy of HCV among current drug users as having a role in the things that you were describing?
Yeah. You know, in some ways, it's a little bit beyond my my expertise. I mean, I know certainly I see in our case rounds where we have seen individuals who have been treated and then become reinfected. And, you know, I think obviously it's nice that Holly's speaking next because she's been sort of pioneering this when hepatitis C was sort of that thing that nobody really worried about in the HIV context. And I think the lessons learned from HIV in terms of strategies to support adherence in that circumstance, daily witness ingestion of methadone, maybe something that is a better fit for someone's very motivated and to support adherence, then that may be a better fit than take-home dosing of Suboxone, which is much more flexible and less of an intensive intervention. So there certainly would be nuances in the hepatitis C treatment context as well as the reinfection context. I might have scooped somebody's question for asking that, so thank you, Julie, for saying that. But yeah, I don't want to paint with too broad a brush here, but I think that would be the biggest one, is how do you engage people, how do you support them, and then how do you try to prevent people sharing needles, and that's the wraparound sort of healthcare service that I think we'd all agree is important.
Thank you very much.
Looks like there's
Just a quick question. Thanks, Evan. That was great. Just, do you know in your discussions with this state of emergency and the addressing the fentanyl problem in Canada, has there been any discussion about hepatitis C? Is that even on the radar screen as something, as a consequence of this explosion of drug use, or not?
Probably not just the top of mind thing. It's come to mind for me when I've seen such desperation, and I think there's maybe something to the fast on, fast off effect of fentanyl that actually does make people more desperate than the kind of heroin situation, that even could we be seeing HIV kind of coming back more where we haven't seen much HIV in the downtown east side. But I think, you know, we're new populations injecting. I think it's perfect segue to the next speaker. But I would say, and Holly would be better positioned to speak to this, I'm not really seeing it just because the overdose thing is the large issue that everyone's talking about. Yeah. Thanks so much.
Thank you.